Good morning, everyone. This is Jose Romero, your chair. I welcome you to the March 1st, second day of the emergency ACIP meeting. We're going to begin here in a moment. Let me see if Dr. Cohn has anything to say at this time. If not, then we'll proceed to take roll.
Just to let everyone know, if they haven't heard yet, that Dr. Walensky, the CDC director, did sign a decision memo approving ACIP's recommendations for use of the Janssen vaccine. And there will be an MMWR published on that tomorrow, Tuesday, at around 1 p.m. Thanks, Dr. Romero.
Thank you, Dr. Cohn. I will now go on to take the roll. This will be only for ACIP members, not ex officios or for liaisons. And for the ACIP members, I remind you to please state your conflicts of interest. There's no need to give your affiliations. So I'll start with myself, Jose Romero. No conflicts. Next is Dr. Alt.
This is Kevin Alt, and I don't have any conflicts.
Thank you. Ms. Bata.
Good morning, this is Lynn Bata, and I have no conflicts.
Good morning. Dr. Bell.
Good morning, Beth Bell, no conflicts.
Thank you. Dr. Bernstein.
Good morning, Hank Bernstein, no conflicts.
Good morning. Dr. Chen.
Wilbur Chen here. I conducted COVID vaccine studies until October 2020.
Welcome. Dr. Daly.
Matt Daly, no conflict.
Thank you. Dr. Cotton.
Camille Nelson Cotton, no conflicts.
Welcome. Dr. Lee.
Grace Lee, no conflicts.
Good morning. Dr. Long.
Sarah Long, no conflicts.
Welcome. Ms. McNally.
Good morning. Veronica McNally, no conflicts.
Good morning. Dr. Paling.
Kathy Paling, good morning. No conflicts.
Welcome. Dr. Sanchez. Dr. Sanchez. I'll come back. Dr. Talbot.
Good morning. Kip Talbot, no conflicts.
Thank you. Good morning. Let me go back to Dr. Sanchez. Dr. Sanchez? All right. Well, let's move forward, and when Dr. Sanchez has an opportunity for in between a question or break, he can chime in and say that he's present. But we do see him on our screens. Okay. So we have a number of topics today that will be covered by various staff here at the CDC. So we'll begin with our first presentations, which are coronavirus disease 2019 vaccines. And again, I will call on Dr. Bell to give an introduction.
Thank you. Could I have the slides, please? Good morning again, everyone, from me. And I just have one or two quick things to say before we proceed with the agenda. Could I have the next slide, please? This is a detailed list of today's agenda. First, we will hear from Dr. Kathleen Dooling of CDC with implementation considerations for COVID-19 vaccines. Then Ms. Jessica McNeil will give us a presentation regarding clinical considerations for the use of COVID-19 vaccines. We will have a vaccine safety session with information from the Vaccine Safety Technical Subgroup known as VAST. First, an introduction from Dr. Grace Lee, who is, of course, as you know, an ACIP member and also the VAST co-chair. A COVID-19 vaccine safety update from Dr. Tom Shinobukuro, and then a VAST assessment of the safety data from Dr. Lee. Finally, we will hear about emerging SARS-CoV-2 variants from Dr. Heather Scobie of CDC. Next, please. Here are the members again. Next, please. And the CDC participants. Next, please. Thank you very much, and I'll turn the virtual podium back to Dr. Romero.
Thank you very much.
Mr. Romero, this is Pablo Sanchez. I'm sorry,
Welcome, Pablo. Good to hear your voice. Any conflicts? Any conflicts of interest, Pablo?
No conflicts.
Thank you very much.
Dr. Romero, this is Bonnie Maldonado. Sorry, I was on an NIH meeting and I was late. Sorry.
Thank you, Dr. Maldonado. So we'll go ahead now. Our next speaker is Dr. Kathleen Dooling on implementation considerations for COVID-19 vaccines. Dr. Dooling, please.
Thank you, very much, Dr. Romero. And good morning, everybody. Next slide. So this morning, we'd like to address the following issues related to vaccination implementation. First, issues related specifically to Janssen COVID-19 vaccine, then COVID-19 vaccine prioritization, and finally, dosing intervals for mRNA vaccines. Next slide. First, let's focus on the use of Janssen COVID-19 vaccines. In the unanimous vote to recommend the Janssen vaccine yesterday, ACIP stated no preference for any of the 3 authorized vaccines. The vaccines were not studied in head-to-head trials, and therefore the results of the Janssen phase 3 trial is not directly comparable with the mRNA vaccines. Janssen COVID-19 vaccine was studied at different calendar time and under different geographical circumstances, which led to differences in the circulating SARS-CoV-2 variants and higher background incidence during their study. The Janssen vaccine demonstrated strong protection against severe COVID with 93% vaccine efficacy against hospitalizations. That was 2 cases in the vaccinated group compared to 29 cases in the placebo group. And moreover, there were no COVID-associated deaths in the vaccinated group versus 7 in the placebo group. Next slide. So, given that the vaccine has been authorized for emergency use by the FDA and recommended by ACIP, how does this vaccine best fit into the national COVID vaccination program? The characteristics of the vaccine are that it is a 1-dose regime and may be transported and stored at 2 to 8 degrees Celsius for up to 3 months. It requires no diluent or reconstitution at the point of use. Next slide. With regard to where Janssen COVID-19 vaccine may be best fit into a vaccination program, jurisdictions may consider use in places such as mobile clinics or pop-up clinics, newly established vaccine administration sites, and sites that do not have freezer capacity, which is the case for most adult healthcare provider offices. It should be noted that the type of vaccine available at any given appointment should be transparent to the consumer. In terms of people who want to be fully vaccinated quickly, people who don't want to return or can't return for a second dose, and mobile populations or homebound populations. Next slide. Ultimately, the workgroup thought that during a pandemic and under an emergency use authorization, offering Janssen COVID-19 vaccine to persons 18 years of age and older, according to established allocation and eligibility recommendations in a given jurisdiction, is an effective implementation strategy. This approach allows for jurisdictional flexibility, supports rapid vaccination and increases population immunity, does not single out any particular group, and finally, allows individuals to be vaccinated with the earliest vaccine available. Next. Let's discuss the vaccine prioritization next. Next slide. The original goals of the COVID-19 vaccine program were to ensure safe and effectiveness of COVID vaccines, to reduce transmission, morbidity, and mortality of COVID-19 disease, to help minimize disruption to society and the economy, including maintaining healthcare capacity, and to ensure equity in the vaccine allocation and distribution. As of February 27th, more than 72 million doses of COVID-19 vaccine have been administered in the U.S. However, jurisdictions continue to face constrained supply and a continued reliance on large vaccination centers. Most jurisdictions are in Phase 1B or expanding to Phase 1C, and most states have made modifications to the ACIP prioritization framework. These modifications include either subprioritization or delayed vaccination of essential workers, adding eligibility age bands for people younger than 65, and subprioritization of high-risk medical conditions or requiring 2 or more conditions. As we look forward towards the next several weeks, by the end of March, vaccine manufacturers have made the following commitments. Pfizer has indicated that they will produce 120 million doses, Moderna committed to 100 million doses, and Janssen committed to 20 million doses. The fulfillment of these commitments will result in a significant increase in available vaccines compared to prior months. Next slide. Even with increased vaccine supply, a number of implementation challenges remain. Here I'll outline responses jurisdictions may consider to meet those challenges. First, adjudicating eligibility in large vaccination centers, particularly on the basis of essential worker status or high-risk medical condition, can be difficult and time-consuming. It should be noted that verification of eligibility should not hamper throughput at large vaccination clinics, and that medical care homes or primary care providers may actually be better able to assess eligibility on the basis of underlying medical conditions. Another challenge is implementing the list of high-risk conditions. The CDC list relies on published studies and is not exhaustive, and certain conditions on the list encompass a wide range of severity. Therefore, clinical judgment may determine if rare conditions not on the list confer increased risk of severe COVID-19. Next slide. Another challenge is that the size of the eligible groups in Phase 1C may exceed vaccine supply. Jurisdictions may consider addition of eligibility age bands for people younger than 65, for example, 60 to 64, 55 to 64, or 50 to 64 as supply permits. This may be particularly helpful in large vaccination settings. Jurisdictions may also consider prioritizing people with 2 or more high-risk conditions. Transmission in congregate settings, such as prisons, homeless shelters, or long-term care facility or other, continues to be a challenge. Jurisdictions may consider offering vaccine to all unvaccinated staff and residents at the same time without waiting for eligibility of each constituent group. Next slide. Another major challenge is promoting health equity while ensuring efficient vaccine distribution and administration. Some strategies jurisdictions can use to improve equitable vaccine distribution are the use of Social Vulnerability Index, or SVI, or other needs-based indexes to place vaccine clinics. Partnering with federally qualified health centers such that they can be vaccination hubs and register eligible community members for vaccination. Offering the Janssen COVID-19 vaccine as an option for populations for whom returning for a second dose would be difficult. And of course, community engagement and education will be important as new COVID-19 vaccines are authorized and recommended for use. Next slide. Next, we'll discuss dosing intervals for mRNA vaccines. There are 2 issues at hand. The first question is around the potential risks and benefits of delaying the second dose of an mRNA vaccine. And the second issue arises around the potential for a single dose of an mRNA vaccine for individuals with confirmed prior SARS-CoV-2 infection. Next slide. As background, extended interdose intervals have been adopted by other national vaccine advisory groups and proposed by individuals in the U.S. as a strategy to increase one-dose coverage during a time when demand exceeds supply. Note that the current CDC guidance is that the second dose should be administered as close to the recommended interval as possible. However, if it is not feasible to adhere to the recommended interval, the second dose of the Pfizer-BioNTech or the Moderna COVID-19 vaccines may be scheduled for administration up to 6 weeks, that's 42 days, after the first dose. Next slide. So with respect to the question of delaying the second dose, in Phase 1 and 2 clinical trials, neutralizing antibodies did not show large increases until after receipt of the second dose. In Phase 3 trials, about 97 to 98% of recipients received both doses on schedule, which makes the study of prolonged intervals almost impossible with this data. The one-dose VE estimates from those trials are between 50 and 90% and are higher when the follow-up time considered is that which happened at least 2 weeks after the first dose, thereby making the follow-up time under study very short. There have been a number of early studies of real-world effectiveness of one dose of the vaccine. One matched case-controlled study in Israel found effectiveness of a single dose in preventing hospitalizations to be 78% between day 21 to day 27. A cohort study in Scotland also examined one dose to prevent hospitalization and found that effectiveness reached a high of 85% between day 28 and 32 days and declined slightly after that. It should be noted that the group with longer follow-up in that study had a higher proportion of older people. Next slide. In terms of the pros and cons of delaying a second dose, the pros are that this strategy could provide one-dose protection to a larger number of people over the next several months. And if one-dose protection is high and persists, this could prevent more infections and deaths. Most experts expect that boosting from the second dose is still likely to be effective even at a longer interval. As for cons, lower neutralization antibodies could be protective against wild-type COVID, but not novel variants. One-dose vaccination could leave individuals susceptible to variants, providing selective pressure and increased transmission of variants. The estimates of effect for a single dose are imprecise, and the duration of protection after the first dose is really unknown. Additionally, a prolonged interval would contradict FDA's emergency use authorization for a vaccine platform for which we have minimal experience. Next slide. In summary, the majority of workgroup members thought that there was currently insufficient data to increase recommended intervals, and that there's important uncertainty regarding protection from the variants following one dose of mRNA COVID vaccine. The next steps on this issue are to continue to monitor post-authorization effectiveness studies. Any updates to vaccine recommendations will be evidence-based, discussed publicly, and made in collaboration with the FDA. Next slide, please. Now, moving on to the question of a single dose of mRNA vaccine for individuals with confirmed prior SARS-CoV-2 infection. By way of background, there have been anecdotal reports of increased reactogenicity following vaccination among people with prior COVID-19. Additionally, recent published reports suggest high antibody response after one dose for individuals with prior SARS-CoV-2 infection. The current CDC guidance states, while vaccine supply remains limited, persons with recent documented SARS-CoV-2 infection may choose to temporarily delay vaccination if desired, recognizing that the risk of infection and therefore the need for vaccination may increase with time following initial infection. Next slide. Immunogenicity following vaccination among persons with prior SARS-CoV-2 infection was evaluated in 2 studies published in preprint. They both assessed antibody titers after one dose in seropositive people compared to seronegative individuals. Both studies showed higher antibody titers in seropositive individuals compared to seronegative individuals after one dose. Next slide. One available preprint study evaluated reactogenicity following mRNA vaccination in seropositive and seronegative persons. It found that localized injection site symptoms occurred with similar frequency between the 2 groups. However, systemic side effects occurred at a higher frequency among individuals with pre-existing immunity. The reactogenicity was similar to symptoms reported after the second dose for people who did not have pre-existing immunity in phase 3 trials. Next slide. In summarizing the pros and cons for the question of a single dose of mRNA vaccine for individuals with confirmed prior SARS-CoV-2 infection, the pros are that this strategy could free up second doses for from seropositive persons to be provided to seronegative persons, and that secondly, that seropositive persons would not receive 2 doses of a reactogenic vaccine. The cons are that current studies included individuals with confirmed antibodies to SARS-CoV-2. Not everyone with prior infection still has detectable antibodies, and performing large-scale antibody screening prior to vaccination is not feasible. Also, correlates of protection are currently unknown, so we are unable to extrapolate antibody studies directly to vaccine effectiveness. There are currently only limited data and small studies. Additionally, a single dose would contradict FDA's evidence-based emergency use authorization for a vaccine platform for which we have minimal experience. Next slide. In summary, the majority of workgroup members thought that there are currently insufficient data to support changes to guidance or recommendations. The workgroup did feel that this was an important area to pursue further data in the coming weeks and months, and that jurisdictions could consider promotion of existing guidance, which is that those with prior infections may choose to temporarily delay vaccination for several months. Next steps are to collect and review further data on safety and reactogenicity, as well as immunogenicity and effectiveness of COVID-19 vaccines among individuals with prior infection. Any updates to vaccine recommendations will be evidence-based, discussed publicly, and made in collaboration with the FDA. Next slide. So that concludes the presentation, and I know we covered a lot of ground there. So these are the questions that we have for ACIP. For the Janssen vaccine, do you agree that offering Janssen COVID-19 vaccine to persons 18 years and older, according to established allocation and eligibility recommendation, is an effective implementation strategy? Next, for vaccine prioritization, we'd like to hear from the ACIP on what are the key challenges and opportunities of implementation guidance options for additional age eligibility brackets for persons younger than 65, and also the possibility of vaccine eligibility based on 2 or more high-risk conditions. And finally, we'd like to hear from the ACIP regarding what are the additional data that are needed to inform the 2 issues, namely the potential for a delayed second dose or for a single dose of an mRNA vaccine for individuals with confirmed prior SARS-CoV-2 infection. So we'd like to tackle those one by one, and then with that, I will turn it over to Dr. Romero.
So before we begin with each of these questions, any clarifying questions or comments from the voting members? Not to address the questions yet, but anything else that needs to be clarified. Dr. Paling.
Yes, thank you for a great presentation. One of the questions is about the high-risk conditions, and could you share what those are currently done in the current list?
Thank you for that question. If you could go to slide 37, it lists the conditions as they currently appear on the CDC website.
Thank you. As you study that, I'll see if there are any other questions or comments. I'm not seeing.
Yes.
Yes.
Can I continue?
Yes, please. I'm sorry.
So my concern with this list is the more frequent it is, the more likely it's going to show up. And for example, thinking mechanistically, type 1 and type 2 diabetes are more similar than different, and they both cause lots of problems. Type 1 diabetes does not make this list because it's less frequent, is what I'm anticipating. And I'm wondering, would it make sense to go after and say this looks a lot like the influenza recommendations for high-risk conditions, and should we adopt those so that you don't exclude conditions that are less common?
Okay, thank you for that suggestion, and I think it's a very reasonable one, and we'll, I think, get into that more in the second phase of the discussion.
So as an ancillary comment to that, states are modifying the definition of diabetes to include type 1. So it already is being modified among states individually. Dr. Sanchez.
Excuse me, this is Dr. Bell. If I could just interrupt. Dr. Dooling, could you put back up the list of questions again? And I'm just hoping we can get to the questions in sequence. so that we end up discussing each of the issues. Thank you.
Thank you. Any other clarifying comments or questions? Dr. Sanchez?
Yeah. I just had a question in terms of the reactogenicity after the first dose that you showed in that study. It was unclear to me. It just had messenger RNA. Is it for both of them? Do you know, is it the Pfizer, BioNTech, or the Moderna that they separate them out?
We're looking that up right now. Let me go ahead and go to Dr. Bernstein while we look up the information for Dr. Sanchez. Dr. Bernstein?
I just had a question relating to the first question brought up, asking about Janssen's COVID-19 vaccine. Is it an effective implementation strategy? And I was wondering if we could, do we have data on the effectiveness of our implementation strategy with the two mRNA vaccines? I asked that because when the phases were developed, we had there were 3 million long-term care facility residents, and the discussion included giving it to the staff in the long-term care facility residents. And yesterday it was mentioned that although there's 3 million, actually 7 million doses of vaccine have been administered to long-term care facility residents. So I was wondering how we were monitoring our implementation strategy.
Thank you for that question, and a great one. And I think evaluation of the implementation strategies is currently ongoing in a number of different ways. But if you go to slide 30, there's a little more detail on at least the procedural outcomes. Next slide, of how many doses have been delivered. So we have actually vaccinated more than 48 million people with one or more dose. That accounts for approximately 19% of the U.S. adult population, 18 and older. And as you mentioned, 7 million doses have been administered in long-term care facilities, which were considered a priority in phase 1A. And of those 7 million, doses have gone to staff and to residents, and more than 1.5 million long-term care facility staff have been vaccinated with one or more doses.
Can I add something?
Dr. Messonnier.
Yeah, I just want to add that I think maybe this is a larger topic, and I know, we have a lot of things to talk about today, but I just want to point out that, we need to be both looking at the safety of vaccine and the effectiveness of the vaccine and our vaccine strategies. And there are a variety and series of studies that we can come back to ACIP with to go through some of those effectiveness studies, looking both at short-term effectiveness and duration of protection. And specifically, there's work now within CDC looking at the impact of the vaccine in long-term care facilities and really trying to disentangle the effect of vaccination and the effect of other mitigation measures. Similarly, there are studies ongoing to look at the effectiveness of our strategies in healthcare workers.
Thank you. Do we have Dr. Sanchez's answer? Please go ahead, Dr. Oliver.
This is Dr. Oliver addressing Dr. Sanchez. It's a preprint article, so we'll follow up when they have the full publication, but in the preprint, they don't specify. They just say single dose of an mRNA vaccine, so they don't specify receipt of specifically Pfizer or Moderna. I'll say that we don't have reason to think that they would be substantially different between the two. Over.
Thank you. I couldn't find it. I was wondering if you had further information. Can I ask another question, though?
As long as it is a clarifying question before we address the primary one. Yes, please do.
I just was wondering about the current guidance of that the second vaccine dose may be administered up to 6 weeks only. I guess I had missed that before, and where that comes in, because that have issues with respect to later dosing.
So the current guidance is to adhere to the 3 or 4 week interval as closely as possible, but where that is not possible, that a 6-week interval can be used for the purposes of scheduling in, I guess, extenuating circumstances. And the 42-day interval was in fact used as the analytic interval in the studies. Very few doses were given out that far, but that was used in the Moderna and Pfizer analysis.
Thank you.
Thank you. Dr. Hayes.
Yes, I was curious if we have any data on the variety of what the guidelines are from state to state, on how each state has made their own decision about who was a priority for the vaccine. Do we have that information, or would that be useful in going forward?
So that information does exist from a number of sources, including the CDC, but not to cut your question short, I'm not sure how it would influence the question that's being asked. Okay, Dr. Long.
I wonder, we've spent so much time on the undersides of the leaves. I wonder if Dr. Dooling has the ability to put up the slide that tells us the tiers and the number of individuals in the United States in the tiers as we try to answer these 3 questions.
Sure. If we can go to slide 31. Okay, so this kind of gives you the schematic of how things were laid out when the ACIP voted on this matter in December of 2020. That the phase 1A were the long-term care facility and healthcare personnel. Phase 1B included persons 75 and older and frontline essential workers. And then phase 1C included persons 65 to 74, other essential workers, and persons 60 to 64 years with high-risk medical conditions. If you go on to slide 32, there we go. So this gives the number of people who were estimated to be in unique individuals in each of those categories. Now, a lot has happened since the time the ACIP voted last. Many jurisdictions have moved to including all persons 65 and older earlier up in their prioritization. And so that has kind of expanded the phase 1B, if you will. But again, jurisdictions have adapted this to their local needs in many different ways.
Thank you very much.
Dr. Cotton?
So I'd like to bring up the list of comorbidities in thinking about where we would use this new J&J vaccine. And I'd like to encourage the enrichment and enhancement of the quality of the comorbidity list.
I'll just say that.
It would be helpful if you could put that slide up. It looks as though they're saying it could be determined by physicians, but I don't think that that's a realistic aspect. And it would be really helpful if we would have better guidance regarding the comorbidities, as many states are relying on that list.
Dr. Messonnier?
Yeah, so totally a valid point and something that is under active discussion right now. I know that there are many issues that ACIP could give us helpful input on, but we do have to ask that in the limited time that we have available, the thing that we really would like you all to focus on right now is the Janssen vaccine and how we would specifically alter or modify or target Janssen's vaccine. So if Dr. Montero, if you could just try to focus us on this question.
I will try to herd the cats, and I say that affectionately, because I am a cat person. So we will try to bring us all in to the direction. And if I seem to be cutting you off on a question, it's because of that issue. Also, can I ask that anyone who's already asked a question, please lower your hand so that I can get a better look at who is speaking and wishing to speak. Ms. McNally.
Thank you. Could I just clarify that on this slide, established allocation is not referencing allocation to jurisdictions, but rather the prioritization? Thank you.
That's correct. We're discussing prioritization within jurisdictions.
Thank you.
Dr. Stinchfield, excuse me.
Patsy Stinchfield from NAPNAP. I'm a dog person, so hopefully my question's okay. As we discussed the eligibility for Janssen, can we also mention any data on ineligibility, those for whom the vaccine would be contraindicated, any conditions we know that should not be given? Thank you.
We are not aware of any, and the FDA information did not include any specific contraindications outside of an allergic reaction to any of the vaccine components.
Thank you.
Dr. Long.
Yes, I think that I certainly would agree with the work group's interpretation that this is not an inferior vaccine, and we should not talk about who shouldn't get it. We should talk about how we can further the desire to immunize hard-to-get populations and to immunize all people by particularly discussing targeting the use of this vaccine. So I would think that it should be prioritized, could be prioritized to what is perceived to be difficult to get to populations that might be homeless individuals, that might be people without access to transportation, who might be people who can't take off work to easily get a second dose without having to lose salary, for people who don't have easy access to the internet, who can get their appointment easily, so that the question would be, how do we best do this without causing more unworkable recommendations, so that it seems harder and harder to do that. But I would focus on who should we try to give guidance to that would further the goal, which is to immunize more people and to decrease inequity. But because it says good a vaccine and can be given in one dose, rather than we wouldn't want to give it to somebody who's at high risk or someone who has underlying conditions because we're not certain of it. I am convinced by the data that we've been shown that these are comparable vaccines.
Thank you, Dr. Long. Dr. Dooling would like to make an amendment in her comment to Dr. McNally. Go ahead.
In responding to Ms. McNally, I believe I misspoke. The current question for discussion, the vaccine prioritization, relates to the entire program, so all vaccines that are available. Thank you.
Dr. Daly, please.
I wonder if we could just pull up the question. Okay, there it is. Now it's back up. So yeah, I just feel like there are a number of negatives to sort of separating the Janssen vaccine out. It would be sort of less valued. It would give local jurisdictions less flexibility. It would be less efficient as a delivery strategy. And it would be less evidence-based because we don't have evidence that it's in any way inferior. Or to state it in the positive, I think I agree with this statement because it gives value, flexibility, administrative efficiency, and the evidence supports it. So I support this strategy.
Thank you, Dr. Daly. Dr. Hutchins.
Okay, I was looking at the previous question about the implementation guidance, and I wanted to make a comment about that as it related to the mobile clinics that are offered. My concern is that if we state that it should be used in mobile clinics for populations or communities that some may consider hard to reach, then there may be introduction of a level of mistrust because it's a single-dose vaccine, and it might lead to increased hesitancy. So I wouldn't target I'm not in support of targeting mobile clinics because those who have run mobile clinics for vaccination know that you can go back to those communities and give another dose or other doses. So we have to be very careful and understand what might be some of the unintended consequences of targeting communities of color who some may feel are hard to reach when they are reachable.
Thank you very much for those points. Dr. Freihofer.
Sandra Freihofer, liaison for the American Medical Association, speaking as a practicing general internist. I have a lot of patients that are immunocompromised, and in the past, like for example, for the live attenuated influenza vaccine, we don't recommend that first line for immunocompromised patients. As we think about how to who to give this vaccine to, now that we have two different platforms, should use in immunocompromised patients be sort of thought about? I know yesterday it's very exciting that we do have a good bit of experience using this platform. The company shared that they have given this vaccine platform to over 193,000 people, including pregnant women and children and infants. However, when we asked about specifics of those details about giving this vaccine in pregnancy, they had not really been published. So at this time, do we feel totally comfortable giving a viral vaccine to an immunocompromised patient?
Thank you for that, Dr. Freihofer. I would like to say that immunocompromise is not a contraindication to this vaccine, and the vaccine itself is not considered a live vaccine. It is not capable of replication, which differentiates it from live vaccines.
Thank you. Ms. Bata?
I'm very much in support of using the established allocation and eligibility recommendations for this vaccine. I think that the states and other local jurisdictions appreciate the nimbleness that this vaccine provides, and it really shouldn't have a preference one over another, again, because of unintended consequences or sending an indirect message that it's not equivalent. It's a very nimble vaccine and very helpful for the response. Thank you.
Thank you. Dr. Lee.
Thank you. I wanted to comment on question one and just state that I agree that, with this particular question, that we should offer the vaccine equivalent to other available vaccines to protect us against COVID. In terms of clarifying questions, well, one, I just want to note that there is extreme variability in the way that obviously those allocations are done state by state and even sometimes county by county. So my assumption is that this question focuses on where we had the initial recommendation around eligibility and use of vaccine. The clarifying question for question one I have is whether or not ACOG could comment on whether or not there are any differences in the ability to offer vaccine, and in particular the Janssen vaccine, to women who wish to be vaccinated if, for example, an mRNA vaccine is not available. My instinct is to say yes, but I would love to hear from ACOG. And then I have a second clarifying question on question two, but I'll wait for the first.
Thank you. Does ACOG?
Okay, sorry, go ahead.
Yes, hi, this is Linda Eckert, and ACOG does not have a preference about vaccines. We feel moving ahead with using the Janssen vaccine is quite appropriate in pregnant patients. Thank you.
Thank you so much. And then the second, if you could flip to the next slide after this, and it is a clarifying question, Dr. Romero, I promise. So I think what would be helpful to me is, I feel, as you know, very challenged by ensuring that we continue to keep equity as a focus for implementation of the COVID-19 vaccination program. And so having information around
age and race ethnicity in terms of severe disease, like hospitalizations or death, would be incredibly helpful to know what the both intended and unintended consequences might be. And then I have another sort of layered question, which is, well, maybe I'll stop there for a second and ask if Dr. Dooling could comment.
Thanks for that question, Dr. Lee. If we go to slide 40. So this is data on deaths in 2020 that were associated with COVID. And this slide basically tells us that for minority groups, a higher proportion of deaths occurred among younger age groups. So as you can see here in the red circle, this is for white, non-Hispanic race ethnicity group. And kind of as we have come to expect, as the older age groups take up a higher and higher proportion of the deaths among that particular race ethnicity group. If we go to the next slide, these are other minority groups, and you see the opposite trend that's happening, whereby the highest proportions of deaths are happening in people in their 30s, 40s, 50s. And you can see this phenomenon among multiple different race ethnicity minority groups. Thank you.
Thank you. Yeah, so I guess given this, I think it'll be helpful to also understand how comorbidities layer in. I do worry about having additional age eligibility brackets, decrementing by 5 years at a time, because I think that functionally delays our ability to potentially effectively reduce deaths, and particularly where there's been a disproportionate share of infection and severe disease in minority populations. So I want to just again highlight that and challenge us to think about implementation efforts in this space. But the other thing I'll just say is that, age alone doesn't tell the story clearly, and the question about comorbidities has come up, whether or not there are additional comorbidities in these age groups. Perhaps the risk is not even across age groups. So somebody who has multiple comorbidities and is 30 or 40 years of age might just carry a different risk of mortality and hospitalization than somebody who is 50 and perfectly healthy. So, I hope that we can continue, and I know Dr. Messonnier had already mentioned that this work is underway, but I think bringing this back into view, I think will be incredibly helpful and useful for those of us on the front line who are trying to figure out how to best vaccinate given the resources we have.
Thank you for those comments. Again, I want to remind everybody that we're focusing on the first question. We will have time to go into the second question and the sub-questions, but again, right now, are there any other comments or questions that need to be asked about this, or do you have a comment about this particular question in front of you right now? Dr. Dries.
Thank you. This is Marcy Dries from Shea. I just wanted to reiterate what others have said, that I do think we should offer this vaccine similar to the other ones to everyone who's eligible. Specific to healthcare workers, they have had access to the mRNA vaccines from the beginning, but many remain unvaccinated. And I do think any who remain unvaccinated should have access to this one as well. They may have preference for a one-dose option. They may still have some uncertainty around the mRNA technology or other reasons why they might want this one instead. And I think it does send a good message that we're comfortable giving this vaccine to healthcare workers, not just other eligible people. Thank you.
Thank you very much for those comments. Dr. Golden, please.
Thank you. I'll be brief and try not to be redundant, but from the American College of Physicians and Primary Care perspective, I certainly think the ethical framework and the allocation strategy that has been previously recommended really is well thought out, and that we should look at all of these vaccines as somewhat interchangeable in the sense of getting the vaccines to as many people as possible. So I'm certainly in favor of maintaining the current allocation strategy and recommendation strategy. The concern I have with the chronic conditions is what we are seeing is many jurisdictions are requiring physicians to certify patients' health conditions putting us in the precarious situation of making the patient have to disclose protected health information and that we have to then sign off on it. So we may want to look at the messaging to make sure that we do not put the physicians and the patients in a precarious position of disclosing their protected health information, or for those who do not have access to health care to have to then be put in that situation of not getting a vaccine because they have no one to certify. And one final point, and then I'll stop, is the concern of preferentially going to certain jurisdictions and making it seem that this vaccine is being reserved for certain areas, minorities, people of color, that might have the unintended consequences of making it seem like an inferior vaccine, which we know it's not. So we really need to message this correctly, that this vaccine is effective. Everyone should get it. It needs to go out to as many people as possible as the other vaccines do, and we really need to respect minorities and people of color to make sure that the front lines get it, which is why an age-based strategy certainly offers me great pause and concern with the ethics and equity. And with that, thank you. Over.
Thank you, Dr. Goldman. Dr. Sanchez.
I just wanted to comment earlier about the possible contraindication or not contraindication in pregnancy, and from from what Janssen presented yesterday, and also I agree with ACOG from a neonatology standpoint that I don't see any contraindication at present for pregnant women from a fetal standpoint to be vaccinated. Thank you.
Thank you very much. Dr. Howell.
Hi, Molly Howell, representing the Association of Immunization Managers, the 64 awardees charged with allocating out COVID-19 vaccine. I just wanted to mention that we did survey our membership, and almost 60% were waiting for ACIP's recommendations in terms of how to allocate out the Janssen vaccine. And so we would appreciate any guidance that could be provided. And I did want to say, I do think in allocations, though, we'll likely have to allocate the vaccine towards certain healthcare providers in order to prevent providers from having multiple different types of vaccine on hand, which could cause administration errors. And so it would be likely that states would allocate towards public health or towards pharmacies in order for it logistically to be allocated easier, and then again to prevent vaccine administration errors by having multiple vaccines on hand.
Thank you, Dr. Howell. Dr. Paling.
So I'm going to agree with the question in front of us. The Johnson COVID-19 vaccine is 93% protective against COVID hospitalizations and deaths. And we know that there is far more demand than supply for vaccine. And so giving jurisdictions the flexibility makes sense to me. And we also need to address the fact that we've had a 1-year decrease, shortened lifespan in Black and Brown communities. That's been 1.9 and 2.7 in the last year. So yes, I'm going to support this. Thank you.
Thank you. Before we move on to the second question, I'll just add my comments, and rather than repeat everything that's been said, I think you can use this this vaccine widely across the groups that we've talked about. We are at a disadvantage in that initial reports on this vaccine focused on the differences of vaccine efficacy compared to the previous two vaccines. And all this to say that messaging must go out to all recipients that this vaccine is effective in prevention of hospitalization and in deaths. And I think that's what we need to stress, what I have been stressing to the constituents in my state. So, Dr. Dooling, do you want to go to the next question?
Yes, please. So the next question addresses the second part of the presentation, and we would like ACIP's feedback on what are the key challenges and opportunities of implementation guidance options for, number one, additional age eligibility brackets that go younger than 65 years, and second, the potential for eligibility based on 2 or more high-risk conditions.
So I will exercise Chairman's prerogative and go first on this. I am not in favor of eligibility brackets under 65 years of age, which is being implemented in some states, because while I feel it's an easier way to distribute vaccine among large populations of the United States, it leads to inequity. And I think that Dr. Dooling presented slides earlier that clearly show that. And that in our rush to administer vaccine, we cannot sacrifice equity. That has been a primary principle of the ACIP in developing these vaccine guidelines, and I think we need to stand by that. So I clearly want to state that I'm not in favor of any type of an age eligibility bracket under 65, and my reason is that the inequity that it will cause. Dr. Lee.
I just want to second your statement, Dr. Romero. I agree completely.
Dr. Paling.
I'm going to agree with your statement and the reasons behind it for the eligibility. I do think the high-risk conditions is concerning. Dr. Goldman earlier explained that he was personally being asked to sign off on conditions. And I would encourage us to think about simplifying the high-risk conditions to something like the flu vaccine, because they seem to be very similar. And I do worry that saying 2 or more will create administrative barriers.
Dr. Dooling, please.
Thank you for that comment, and I'd like to call on a subject matter expert to working on the list. Dr. Naeem Logan, are you with us?
Yes, I am.
Would you like to speak to the list and potential future directions as stated by the previous speaker?
Yes, Dr. Dooling, thanks for inviting me here. I'm representing CCU, which is the core clinical unit, and also the Health Systems and Worker Safety Task Force as part of CDC's COVID-19 response. In attempting to answer this question, I think it may be helpful to first provide some context, which I feel will be very clarifying. So this list, the consumer webpage, as we refer to it, is and always was intended with the primary purpose of informing individuals about their level of risk. So that said, this list is not exhaustive. It does not include every condition that may increase one's risk for developing severe COVID. So this is clearly stated in the current webpage. Now, we understand that ACIP provides a framework for decision-making regarding the vaccine prioritization, and we realize that Phase 1C highlights high-risk medical conditions, and we understand the challenges that all of you are facing. But it's important to remember the original intent of that list, and also the inherent disadvantages of using this list solely for vaccine allocation. So I'll just end by stating that it was always expected and indeed hoped that healthcare providers and jurisdictions would also consider additional medical conditions, individual patient and logistical considerations when planning COVID-19 vaccination. Thank you.
Thank you for those comments. Dr. Daly.
Yes, so I just wanted to say that I agree, Dr. Romero, with your assessment. I don't think it's a good idea at this point to go to age bands, and I also don't think it's a good idea to look at eligibility based on 2 or more high-risk conditions. As some folks on the call may be aware, I brought up this issue about age bands on a COVID vaccines workgroup call, in part because I was asked by local public health who said they were struggling with figuring out how to implement that at mass vaccination clinics. And so while I appreciate the challenge that local public health is facing with implementation, I think the solution is not to abandon the strategy that we've taken for exactly the reasons that you outlined, Dr. Romero. I think it is more likely to increase inequality. Thank you.
Thank you. Dr. Long.
I find this one a little bit more difficult, not because of the principle, and if we're thinking about equity first, I do believe that the current recommendations are just unmanageable, and that there are some states, some jurisdictions, some healthcare providers who currently are giving this to their patients who are much younger. I'm also concerned that those multi-generational families are not eligible so far, and most of those are younger people in this age group taking care of older individuals. So that although we're doing this because we are principled in equity, I think the translation of our guidance has, in some situations, allowed inequity, which is those that have good follow-up in healthcare systems who don't have underlying conditions may be getting this, when those who don't have a medical home or are less well cared for or less facile with the way in which you get on lists are not getting it. So that I hope we can simplify, clarify at least the risk conditions to make that at least manageable. But I hope this recommendation is not for longer than 30 to 60 days, because we would want to pivot to be able to give this to everyone.
Thank you, Dr. Long. Dr. Talbot.
Yeah, so I had a few comments in response to this. So my other daytime job is collecting information on people hospitalized with COVID. And so, Cassie, I just want to point out that Dr. Paling was correct in that the most common conditions in the U.S. are the ones that come up first, and the rare ones are not. And so I think simplifying the high-risk conditions like we did for flu would have great impact. However, I would not do 2 or more high-risk conditions, because you could have a well-controlled diabetic and a well-controlled hypertensive who get in line before someone who has poorly controlled diabetes. So I think, and I don't think we should start trying to make hierarchies of whose disease is more severe than others. And we don't know the impact of certain diseases compared to others when it comes to your risk for COVID. I think this is one of those times, once again, that we have to stress our goal is to vaccinate everyone with a high-risk condition. Actually, our goal is to vaccinate everyone in the U.S. And I think we just have to tell people that we are working our way to getting them all vaccinated. Please be patient. And this is, if you have a high-risk condition, we want you in line next. I don't really need to know which one. I don't need to know how many. I just need to know that you have one. And I don't feel like we should make anyone police this. There are going to be people who cheat, but there's always someone who finds a way to cheat. And I don't think we should waste our time arguing about that or thinking about it. So I think we should continue moving with the brackets that we have defined, not age brackets, but certain groups, and then have people with high-risk conditions that we simplify and be more inclusive to really represent probably what is high risk and not what we've collected necessarily in EIP. And then move forward and let people get vaccinated, knowing that we're going to have less than we need, but we will get there. Thank you.
Thank you, Dr. Talbot. Dr. Bell, please.
Thank you. I wanted to make a couple of comments about this list issue, keeping in mind a couple of overarching points. One, first being that, we on the ACIP want to be as helpful as possible at any particular juncture to further the goals, as Dr. Dooling laid them out. And second, that what we're doing here is providing guidance or advice to CDC. And so you heard, I think Dr. Messonnier said earlier, please tell us what to do, what you think about the Janssen vaccine. And I think we have provided some feedback there. And now we're on this issue of the list, where I think that, as you can hear, and as I've been hearing as the chair of the work group for quite some time, there's a lot of anxiety and sort of displeasure with this list. You heard from Dr. Cotton earlier. And while I recognize that we're at a certain juncture, I'm hopeful that within a month we won't have to worry about this list. I still think that the list is currently really a problem and a barrier for many on the front line, many states, not all states, and that there therefore is a need to address this list in some way. Now, you heard from Dr. Logan from the relevant group at CDC that it sounds to me from what she's saying that what they are doing, what she is doing in terms of the list, is not actually going to address the concerns raised by the committee. And, one could make the case, but the reality is that the ACIP has used this list, and we can't rewrite history. So I guess what I would suggest, or what I would hope, I feel that it's going to be very difficult for the ACIP to do anything other than state what we think the objectives of improving the list should be. And as we've heard, I think there are some concerns about complexity. There are concerns about accuracy, to use probably not exactly the right word. And so I guess I would really hope that CDC, perhaps not through the process that Dr. Logan is charged with, but through some process, can in fact address these concerns that we're hearing very loud and clear about the current status of this list. Thank you.
Thank you very much, Dr. Bell. Dr. Sanchez.
Thank you, Jose. I just want to say that, and agree with some of the previous comments. Certainly, it's a really difficult decision now, going less than 65. Certainly, it is the age strata, and defining who receives it by age strata is certainly the easiest, because at least we have something concrete that we can decide. And really, among the states that have done it, in those who are over 65, I can recognize why they did it, because at least in Ohio, what we're told is that the majority, 87, 85, 90% of the deaths were in those over 65. So I can understand why some of the states did it that way. I understand the need for equity, but I also understand the need that there are certainly high-risk conditions that put these individuals at higher risk that need to be considered, whether there's a list or what. I agree with the fact that documentation is not going to be feasible, but I do think that high-risk conditions are essential. I also think that we have to start including contacts of individuals who are high risk themselves, particularly the elderly. This has been brought up before. Those who care for elderly, infirmed individuals, elderly people at home who are not in nursing homes and chronic care facilities. I think those younger individuals need to be also prioritized, and even those contacts of cancer patients and others and other immunocompromising conditions. So I think that it becomes very problematic. Hopefully, with the Janssen product and the availability of vaccines, we hopefully won't have to be dealing with this for much longer, because our goal is to vaccinate the entire population.
Thank you. We're going to take three more comments, and then we'll move on to the next question. Let me start with Dr. Bernstein.
Thank you. This has been a great discussion, and certainly there are not a lot of easy answers. I was wondering whether, and it may be relate more to just the general picture, but in looking at the phased allocations that we have and the number of unique persons in each group, when we look at it, if I'm doing the math right, the number of unique persons in each group for phases 1A, 1B, and 1C is 202 million, and 72 million doses have already been administered, and 240 additional doses from the 3 manufacturers are anticipated this month. So I think that broadening this in order to reach as many people as possible might be the direction to go, and I wonder whether we should be more lumping than splitting, and perhaps we don't need phases 1A, phase 1B, phase 1C, but those as the amount of vaccine that's being distributed, larger number of doses available, I think we can broaden this, including those in different age groups and high-risk conditions without documentation from any provider.
Thank you. Dr. Paling?
Thank you. So I was thinking along the lines of Dr. Bernstein, because when I add up the numbers expected by the end of March, it's 160 to 170 million doses will be distributed in the month of March, and so there should be a lot more people who should be able to be vaccinated. With that, I am concerned about saying 2 or more high-risk conditions. One is because it's kind of trying to judge who is at higher risk when we don't have that data. The second is I worry that having 2 diagnoses will create health inequities because access to care would be related to the number of conditions you've been diagnosed with. The third question is when we write the MMWR for the update on the vaccines, is this an opportunity to update how list and high-risk conditions? Thank you.
Thank you.
So this is Amanda. I just want to update and remind everybody, just let everyone know about updated materials. So the MMWR will just discuss the Janssen recommendation that was made yesterday. What we're talking about here is a separate web-based document that's an implementation guidance. It's more nimble. We can update it more frequently. And then the list, if that would be the implementation guidance is around sort of how to think through this list, but the list itself is in the process of being updated already as described earlier.
Very good. Final comment by Dr. Lee.
Thank you. I wanted to comment, so I'd already commented about the age-specific question, but I wanted to comment on the 2 or more high risk. I will agree with my colleagues that I do believe we should not be stating 2 or more high-risk conditions for a couple of reasons. One is we don't have enough information to really compare high-risk conditions. We need that information, but we don't have it. So I think trying to implement based on that makes an assumption about the science and the data that we just don't have. The second thing is just that in 2 examples. In pediatrics, if you look at the proportion of people who are hospitalized, the most common condition is obesity. And it doesn't necessarily mean that you have other comorbid conditions in children, in the pediatric and young adult population. And I do believe that we need to make sure that we are inclusive, and particularly for younger populations that may not have multiple comorbidities, that we are able to vaccinate or have the access to vaccination for the younger adult and older teen population. That also includes an example of pregnancy, which is a high-risk medical condition, but requiring 2 would make no sense because that would exclude nearly all or the majority of pregnant women that we see. So I would strongly state that I would not want us to move towards 2 or more high-risk conditions for implementation. The other thing that I actually just want to make a point of is, 2 other points. One is I do want to just state for the record that primary caregivers of folks who can not get vaccinated, but those individuals are at highest risk, I do think should be, prioritized above the general population. So an example being stem cell transplant patients whose families or primary caregivers are with them around the clock. Being able to protect those individuals in the absence of any high-risk medical condition, I think, in and of itself is important, in part because we can't vaccinate young kids at this time until we have vaccines available for kids. And then my final point I wanted to make is that I just think that at this stage in the vaccination program, we need to move away from a punitive approach to an improvement mindset in how we're thinking about vaccine implementation. I just know that so many facilities are extremely worried about getting it exactly right that I think it's actually inhibiting access, except for those to those who might be the strongest self-advocates. So I think the more restrictions we place on things, I worry that it continues to inadvertently create a disincentive for us to do enhanced outreach. And since our intent is to vaccinate everyone anyway, other than the most egregious of situations, whether or not I get high-risk condition A versus B correct, I think is less important than just making sure that we are providing access. So, I would ask our states and jurisdictions to start to move us towards a more positive mindset in thinking about how we can continue to improve on getting it right, as opposed to penalizing folks who may not be perfect. Thank you.
Thank you for those comments. Very good. So we'll now move on to the next question and sub-questions. Dr. Dooling, please.
Thank you, Dr. Romero. So the final segment of this question and comment period is around mRNA vaccine dosing, and specifically what additional data is needed to inform decisions in this area. And the two questions we discussed are the potential for a delay of the second dose and also a single dose of mRNA vaccine for individuals with confirmed prior SARS-CoV-2 infection. Dr. Romero?
Open for questions or comments regarding this. Dr. Sanchez.
Thank you, Dr. Romero. I just wanted to just go back a minute and just say that I completely agree with Dr. Lee. And I think that I don't agree with the requisition for two medical risk categories. But with respect to this one, I don't think we're there for delaying a second dose of the messenger RNA vaccine. I feel that we really need to go where the randomized trials showed optimal efficacy. And so I really don't agree with delaying the second dose at this time because we really want to bring this pandemic under control, especially those who have already received the vaccine. I think that that if we start to delay it and we start seeing some more COVID infections in those who received one vaccine for whatever reason, because it's less efficacious, then we're going to have also a lot of questioning as to whether the vaccine is needed at all. And so I really think strongly that we need to abide by the current recommendations and guidance, because that is what the study, and that's what the evidence so far has shown. In terms of the single dose of messenger RNA for individuals with confirmed prior one, I really think that that's a really intriguing and important question. At this point, I probably would go along with what I've said previously, but my gut impression is that these individuals are likely not going to require a second dose. And as soon as we can gather sufficient information on that, I think it would be extremely helpful, because I think that one infection probably has, they're able to develop an amnestic response with probably like a booster type dose. So but at this point, probably it might be too early, but I would consider that a possibility of moving towards that quickly. Thank you.
Dr. Talbot.
I'm going to comment on number 2, second question. I don't need any more data. We've all taken immunology. We know there's a prime boost. They've primed, we'll boost. We're done with one dose. And I think the data that was shown was incredibly helpful already, and I think we can go ahead and make a decision on number 2 and not wait. Thank you.
Ms. Bata.
I want to second what Dr. Sanchez said about the second dose, that we need some more information, especially in light of what's happening with the development of variants. I think that it could go one way or the other. Getting more doses out, first doses might stop this, but only having first doses might treat it. And for the second question, I probably don't know enough immunology, but it would make sense from a priming and boosting that a single dose may be necessary. But what I'd want to know is a little bit more about the behavior of coronaviruses and how the vaccination might compare to diseases and reoccurrence of diseases. Thank you.
Thank you, Dr. Bata. Dr. Lee.
Thanks. Agree that we don't have sufficient data to delay the second dose beyond what is currently recommended. If there were large-scale data to inform that, I would, of course, we can always be dynamic about our decision-making process and rethink that decision. But I am comfortable where it stands right now, up to 6 weeks. And then the second question, I agree wholeheartedly with Dr. Talbot, in part because I do feel like that the infection is the prime and that the vaccine is the boost. And I don't see any advantage to giving a second dose, either from an immunogenicity standpoint or from a safety standpoint. I really feel like the second dose is not necessary. And, again, in order to be able to ensure that we are thinking about the benefit-risk balance, I don't believe it's needed. So I would actually want to make a clear statement about that now. Actually, I have sufficient evidence for that now.
Thank you very much, Dr. Lee. Dr. Long.
I agree with everything everyone has said so far. For all of the reasons that you've presented, we should not do anything about delaying a second dose, and it'd be very confusing. It would help for only a very short period of time, et cetera. Regarding the second question, I would like to see later some more data on harm or systemic reactions, if we have that, of people who previously had coronavirus disease. I think it is a considerable concern. I think we might even get to the question over time with more data, should they get a first dose? My own brother, who lives in Alaska where there was no coronavirus early in March, did get coronavirus, was severely ill, is recovered fully, had a central nervous system vasculopathy 8-9 months later, from which he recovered, which there was no reason for him to have it other than maybe being related to coronavirus, and got his first vaccine and had a recrudescence of the central nervous system symptoms. And whether that's specific for coronavirus, I don't know for a minute. It may have been just an inflammatory response. But I think we even need to know whether the first dose confers enough benefit to be worth the risk of harm. So it seems very easy for me to say the second dose would have so much more likelihood of harm than benefit that we should maybe leave that in abeyance until, or relative contraindication until we know more.
Thank you. Let me make my comment here because the question that is being asked is a single dose mRNA for individuals with confirmed SARS-CoV-2. What other additional information is needed? So I agree with the theory and the science that's already been presented, but remember that the data that we have on the boosting after the first dose in individuals previously infected are in individuals that already have adequate or high titers of antibody to SARS-CoV-2. The question in my mind is what happens to those individuals that have no antibody at the time they're being sampled, have very low antibody? And while I agree that an anamnestic response is most likely to occur, are we certain that they have enough memory B cell available to boost to levels that will be protective? Those are the studies that I think that need to come forward. And I'll end my comments there. Dr. Stinchfield.
Yes, Dr. Romero, Patsy Stinchfield, NAPNAP, thank you. I totally agree with what you just said, and it was what I was going to say. I do think we need to know the longevity of our protection, and I have not been a fan of the recommendations to delay the second dose, most out of concerns about the variants. And I'm reflecting on that good science, ethics, and implementation triangle that our CDC colleagues remind us to think about. And in the implementation side of this, most of our scheduling systems are developed for the 2 doses, and you make your first and second appointment at the same visit. And so to change that would be a significant lift on the ground at the implementation side.
Thank you. Dr. Bernstein.
Thank you. As for number one, I agree that we should go where the science leads us as far as that concerned. So I think we should stay where we are at the moment. As far as number two, I also agree with you, Dr. Romero. I think we need more data about correlates of protection and duration of immunity, and also how the current mRNA vaccines fit with variants that are increasing in the community. So I'm not so enthusiastic about going with a single dose in those that have confirmed prior SARS-CoV-2 infection.
Thank you. Dr. Bell.
Thank you. I wanted to, talking about this question number 2 about people with prior infection, and I wanted to agree with your comment, Dr. Romero, and say that this clearly, I think, is something that it is important and should be a priority to get some additional data about, because I think to Dr. Long's point, we certainly don't want to be doing harm. But on the other hand, I myself am not comfortable with making a recommendation because it makes immunologic sense. We just don't know enough about the unintended consequences. And there is this issue of how do we know who actually has antibody and who doesn't have antibody, and what happens with a single dose if you don't have antibody. We just don't know enough. But I once again, actually, to back to the point of what can ACIP do, I think that it would be very useful for us to send a very strong message that this does need to be something that a priority for study. And you could imagine that it actually might not be logistically that difficult to get some of this additional data so that we can make evidence-based recommendations about this topic. The other thing I wanted on this topic to raise for some additional discussion is the recommendation about how long after SARS-CoV-2 infection a person should get vaccinated if they choose to be vaccinated. And currently it says one might consider waiting for 90 days. But my understanding, at least anecdotally, is that there are a lot of people who rush to get a vaccine after infection. And so I'm wondering if people have an opinion about whether it would be useful to clarify or strengthen guidance about waiting a bit after a confirmed infection, even to get a single dose.
Thank you, Dr. Bell. Dr. Sanchez?
Yeah, I just had more comments. I agree that more data are likely needed for number 2 about just a single dose, although, I think that in terms of those who've had a symptomatic disease, they very likely will have had an immunologic response. So I tend to think and agree with some of the previous comments that those who've had a significant, but it's hard to put into words, but those who've had symptomatic COVID-19 infection, I think those, I even worry about the first dose because of the reactogenicity. But I think that those individuals likely do not require a second dose. And then I also think that we need a little bit of guidance in terms of the 6 weeks delay, and maybe scheduled for administration up to 6 weeks, 42 days after the first dose. What happens if, for some reason, they delayed it beyond 6 weeks? And I think that, if I remember correctly, they don't have to be reimmunized at all. You just get the second dose.
Thank you, Dr. Sanchez. Dr. Fink, please.
Yeah, thank you. I just wanted to chime in support of statements made by you and Dr. Bell and others that we would all like to make the best recommendations possible to cover the universe of potential circumstances. And I acknowledge that ACIP has the difficult task of coming up with recommendations to cover situations and circumstances that aren't covered in FDA-approved labeling, and even on occasion makes recommendations that are off-label for approved products when those recommendations make sense and are backed by data. But the fact is that at this time, these COVID-19 vaccines remain unapproved products. They're available under emergency use authorization, and the labeled use under emergency use authorization is based on data that are sufficient to support that use, but data that are rapidly evolving and that we are continuing to gather. And I agree entirely that gathering more data to inform use in previously infected individuals and to inform potential changes to dosing intervals should be a priority. But at this time, we certainly don't have data to support any of the types of proposals that are being discussed in labeling for these unapproved products that are available under emergency use authorization. Thank you.
Thank you, Dr. Fink, for those comments. Dr. Cotton.
I wanted to say regarding number 2 that I'm actually comfortable with the immunologic data and going with a single dose for confirmed infection. There may be a need for boosters in the future, which will be an interesting area that I don't think we have significant information on. We also will hopefully have more information about correlates of protection that will help us make good decisions. I would like to say, though, that I think the single dose for mRNA vaccine for people who had infection would be acceptable for healthy people, but would, based on my experience as a clinician who cares for a lot of immunocompromised patients, it probably would not be adequate for that population. So it will be challenging to make a guideline that would fit everybody, and we probably would need to distinguish among different at-risk cohorts.
Thank you, Dr. Cotton. Ms. McNally.
Thank you. I have 2 questions, please. So the first is, I'm looking at slide 23 of Dr. Dooling's presentation, where under issue 2, it says next steps, and the third sub-bullet says that any update will be made in collaboration with FDA. So my first question is there a formal collaboration process, or are these more ongoing discussions? And if so, how the public becomes aware of the ongoing discussions? And my second question relates to the reactogenicity. for individuals with prior infection and how they are becoming aware of that potential side effect. Thank you.
So, Ms. McNally, is this the slide that you were talking about, 23? Is this the correct slide?
No. So this is the one. Let's see. It's this one. Yes. Apologies if I was wrong on that numbering.
No, that's fine. We just want to have it up there.
Thank you for those questions, Ms. McNally. So in terms of the ongoing, as it's stated, decision would be made in collaboration with FDA. So there are numerous avenues for that collaboration. Informal as another agency within the HHS structure. And in addition, in the collaborations that we have here at ACIP with currently Dr. Doran Fink being the ex officio member that represents FDA at the ACIP table, and he also sits on the work group of the COVID work group of the ACIP, to name a few. To go to your second question about reactogenicity, there are no current mechanisms to state that there is any difference in reactogenicity for persons who may have had prior infection.
Thank you.
Dr. Dooling, just to follow up, are there plans to discuss that information? I mean, if we're evaluating and potentially going to make an evidence-based change, I'm just wondering if that is something that is currently being discussed, adding to the EUA or other clinical guidance. Thank you.
Ms. McNally, this is Amanda. Yes, we are currently trying to assess our data sources and our ability to look at whether or not there's increased reactogenicity or adverse events among people who have previously had infection with that second dose. We've been pulling this together over the last little while, and I can't quite tell you when we'll have an update for ACIP. But it will be soon.
Thank you, Dr. Cohn.
So I see no further questions or comments, and let me look to Dr. Dooling to see if we provided you with sufficient information on the questions, and she's nodding yes. So we end this session then. We're now going to proceed with the remaining presentation of our morning session, which is from Ms. McNeil, and it's regarding clinical considerations for the use of COVID-19 vaccines. Ms. McNeil.
Thank you, Jose. Today I will be reviewing CDC's clinical considerations for the use of COVID-19 vaccines in the United States. Next slide. CDC's clinical considerations for the use of mRNA COVID-19 vaccines were presented to ACIP in December and are published on the CDC website. Today, I will present proposed updates to these clinical considerations to include information on the newly authorized Janssen viral vector COVID-19 vaccine. I will also highlight other key updates that have been made to the clinical considerations since the December ACIP meetings. These considerations will continue to be updated as additional information becomes available or if additional vaccine products are authorized. I also wanted to highlight for you that you can sign up to receive email updates when the clinical considerations are updated by scrolling to the very bottom of the webpage listed on this slide. Next slide. So first I'll start with vaccine administration. Next slide. The COVID-19 vaccines are administered intramuscularly as either a 2-dose series or as a single dose. One valid vaccination series should be administered, meaning either a 2-dose mRNA COVID-19 vaccine series or a single dose of Janssen COVID-19 vaccine. Individuals are not recommended to receive more than one complete COVID-19 vaccination series at this time. The vaccine, authorized age group, dose volume, number of doses in the vaccine series, and the interval between doses are described in this table, which is also included in the clinical considerations document. Oops, next slide. Chris, go back. We're ahead one. Okay. Okay. Any of the currently authorized COVID-19 vaccines can be used when indicated. ACIP does not state a product preference. However, the COVID-19 vaccines are not interchangeable, and the safety and efficacy of mixed product series has not been evaluated. In exceptional situations where the first dose of an mRNA COVID-19 vaccine was received, but the patient is unable to complete the series with either the same or a different mRNA COVID-19 vaccine, for example, due to a contraindication, a single dose of Janssen COVID-19 vaccine may be administered at a minimum interval of 28 days from the mRNA COVID-19 vaccine dose. And I'll come back and talk about this group a little bit more in the precautions and contraindications section of this presentation. However, these patients should be considered to have received a valid single-dose Janssen vaccination series, not a mixed mRNA viral vector vaccination series. Next slide. The currently authorized COVID-19 vaccines are all inactivated vaccines. COVID-19 vaccines should be administered alone with a minimum interval of 14 days before or after administration with any of the other vaccines. However, a shorter interval may be used in certain situations where the benefits of vaccination are deemed to outweigh the potential unknown risks of vaccine co-administration. For example, tetanus toxoid-containing vaccination as part of wound management, rabies vaccination for post-exposure prophylaxis, or measles or hepatitis A vaccination during an outbreak. Or to avoid barriers or delays in COVID-19 vaccination, for example, in long-term care facility residents or healthcare personnel who received influenza or other vaccinations prior to admission or onboarding. Next slide. Next, I will review the considerations for vaccination of people with SARS-CoV-2 infection. Next slide. Vaccination should be offered to persons regardless of a history of prior symptomatic or asymptomatic SARS-CoV-2 infection. Data from clinical trials suggest that the currently authorized COVID-19 vaccines can safely be administered to persons with evidence of a prior SARS-CoV-2 infection. Viral testing for current infection or serologic testing for prior infection is not recommended for the purpose of vaccine decision-making. Next slide. Vaccination of persons with known current SARS-CoV-2 infection should be deferred until the person has recovered from the acute illness, if the person had symptoms, and criteria have been met for them to discontinue isolation. While there is no recommended minimum interval between infection and vaccination, current evidence suggests that reinfection is uncommon in the months after initial infection. Thus, while vaccine supply remains limited, persons with recent documented SARS-CoV-2 infection may choose to temporarily delay vaccination if desired, recognizing that the risk of reinfection and therefore the need for vaccination might increase with time following initial infection. Next slide. Currently, there are no data on the safety and efficacy of COVID-19 vaccines in persons who received monoclonal antibodies or convalescent plasma as part of COVID-19 treatment. Based on the estimated half-life of such therapies and evidence suggesting that reinfection is uncommon in the 90 days after initial infection, vaccination should be deferred for at least 90 days. This is a precautionary measure until additional information becomes available to avoid potential interference of the antibody therapy with vaccine-induced immune responses. This recommendation does not apply to people receiving antibody therapies not specific to COVID-19 treatment, and there is currently no recommended minimum interval between antibody therapies not specific to COVID-19 treatment and COVID-19 vaccination. Next slide. Next, I will review COVID-19 vaccination in special populations. Next slide. COVID-19 vaccines can be administered to persons with underlying medical conditions who have no contraindications to vaccination. The clinical considerations document includes information for vaccination of immunocompromised persons, those with autoimmune conditions, and persons with a history of Guillain-Barré syndrome, Bell's palsy, and dermal filler use. Clinical trials have demonstrated similar safety and efficacy profiles in persons with underlying medical conditions, including those that place them at increased risk for severe COVID-19 compared to persons without comorbidities. Next slide. Persons with HIV infection, other immunocompromising conditions, or who take immunosuppressive medications or therapies might be at increased risk for severe COVID-19. Immunocompromised individuals may receive COVID-19 vaccination if they have no contraindications to vaccination, but should be counseled about the unknown vaccine safety profile and effectiveness in immunocompromised populations, as well as a potential for reduced immune responses and the need to continue to follow current guidance to protect themselves against COVID-19. Next slide. Observational data demonstrate that pregnant people with COVID-19 have an increased risk of severe illness, though the absolute risk is low. Additionally, they may be at increased risk for adverse pregnancy outcomes. There are currently limited data on the safety of COVID-19 vaccines in pregnant people. No safety concerns were demonstrated in animals that received any of the 3 authorized COVID-19 vaccines. In addition, the adenovirus vector platform used in the Janssen COVID-19 vaccine has been used for other vaccine development programs that included pregnant people vaccinated during any trimester, including a large-scale Ebola vaccination trial. No adverse pregnancy-related outcomes, including infant outcomes, were determined to be related to the vaccine in these trials. Based on current knowledge, experts believe that COVID-19 vaccines are unlikely to pose a risk to the pregnant person or fetus because the currently authorized COVID-19 vaccines are all inactivated vaccines. However, the potential risks of COVID-19 vaccines to the pregnant person and fetus are unknown because these vaccines have not been studied in pregnant people. Clinical trials to evaluate safety and efficacy of COVID-19 vaccines in pregnant people are underway or planned, and the vaccine manufacturers are following outcomes in pregnant people in clinical trials who became pregnant. Next slide. Pregnant people may choose to receive a COVID-19 vaccine when eligible. A conversation between the patient and their clinical team may assist with decisions about the use of COVID-19 vaccine, though a conversation with a healthcare provider is not required prior to vaccination. When making a decision, pregnant people and their healthcare providers should consider the level of COVID-19 community transmission, the patient's personal risk of contracting COVID-19, the risks of COVID-19 to the patient and the potential risks to the fetus, the efficacy of the vaccine, the side effects of the vaccine, and the limited data about the use of the vaccine during pregnancy. Next slide. I will now review the contraindications and precautions for COVID-19 vaccination. Next slide. Recommendations for contraindications and precautions for the COVID-19 vaccines are summarized in this table. Beginning at the left in the red box are contraindications to vaccination. Contraindications to vaccination include a history of severe allergic reaction after a previous dose or to a component of the COVID-19 vaccine, or an immediate allergic reaction of any severity to a previous dose or a known diagnosed allergy to a component of the vaccine. Individuals with a contraindication should not be vaccinated, and consideration could be given to referral to an allergist, immunologist, and providing another vaccine alternative. In the yellow box are precautions to vaccination. Precautions include persons without a contraindication who have a history of any immediate allergic reaction to other vaccines or injectable therapies. Those with a contraindication to mRNA COVID-19 vaccines have a precaution to Janssen's COVID-19 vaccine and vice versa. Individuals with a precaution should receive a risk assessment and referral to an allergist immunologist, and if vaccinated, these individuals should be observed for 30 minutes following vaccination. Finally, the green box summarizes people who can proceed with vaccination. Individuals without a contraindication or precaution, but with a history of allergy to oral medicines, foods, pets, etc., or with a family history of allergies can be vaccinated. In these situations, a 30-minute observation period should be used with individuals with a history of anaphylaxis due to any cause, while a 15-minute observation period can be used for all other people. Next slide. This next table summarizes information related to the contraindications and precautions by vaccine type. Beginning with mRNA COVID-19 vaccines, persons with a contraindication to one mRNA COVID-19 vaccine should not receive doses of either mRNA vaccine. These individuals also have a precaution to the Janssen COVID-19 vaccine because it is not yet known whether the 3 vaccines contain cross-reactive allergens. Similarly, persons with a contraindication to Janssen vaccine also have a precaution to mRNA COVID-19 vaccines for the same reason. And finally, as discussed previously, in persons who received one mRNA COVID-19 dose, but are contraindicated to receive the second dose, consideration may be given to vaccination with Janssen's COVID-19 vaccine in an appropriate setting under the supervision of a healthcare provider experienced in the management of severe allergic reactions. If vaccinated, these individuals should be observed for 30 minutes following vaccination, and in addition, referral to an allergist immunologist for consultation could also be considered. Next slide. Next slide. So today we'd like to get ACIP's opinions in the following areas. Does ACIP agree with the proposed clinical considerations related to vaccination, and are there any sections of the clinical considerations that ACIP would like to discuss? Thank you.
Thank you for that presentation, Ms. McNeil. Open for questions or comments. Let me begin with one question. In terms of when to begin quarantine for these individuals, will the current guidelines, that is saying 14 days after receipt of the second dose of an mRNA vaccine, an individual who has been fully vaccinated does not have to enter into quarantine, will that 14 days apply to the Janssen vaccine product, the adenovirus vaccine product?
Thanks for that question. So yes, the current version of the clinical considerations does include public health recommendations for vaccinated people. And this has been updated to say that people are considered fully vaccinated 2 weeks following receipt of the second dose of a 2-dose series, or 2 weeks following receipt of a 1-dose one dose of Janssen's vaccine. I also want to note that this section of the guidance will likely be removed in the next week or so, and pulled out and put in with additional recommendations around quarantine for vaccinated individuals. So for now it's included, but likely it will be removed soon.
Thank you very much, and for that teaser. Dr. Dries.
Yes, thank you. I have two questions. One is related to the contraindication. You said in the beginning part of the presentation that someone who received 1 dose of an mRNA vaccine, but then was unable to get the second dose, such as due to a contraindication, could get 1 dose of the Janssen vaccine. However, you also said that some of the ingredients are similar, the polysorbate and polyethylene glycol. So if we have patients who had a possible allergic reaction to the first vaccine, should we or should we not advise them to get the Janssen vaccine to complete their series?
Thanks for that question. So this is an area we're still talking about and considering. Right now, the way the considerations are written, persons who had a contraindication, so an anaphylactic reaction to a dose of either mRNA or Janssen vaccine, they would be considered to have a precaution against vaccination with the other type of vaccine. And so they would, if they were vaccinated, they'd need to be vaccinated in a setting where those reactions could be managed, and they would also have a 30-minute observation period.
Okay, thank you. And then my second question is, given, I know we're going to review the safety data later today, but the risk of anaphylaxis that's been presented for the Pfizer and Moderna vaccine is, in the past has been very low, 2 to 5 cases per million doses given, which is pretty similar to other vaccines that we don't require 15 minutes of monitoring for. And it's what I remember is the majority of those were in people with a history of severe allergy of one type or another. Has there been consideration to drop that requirement or recommendation for 15 minutes of monitoring for people who don't have that allergy history? Thank you.
Right. So our usual recommendation for any vaccine is that somebody should be monitored for 15 minutes following vaccination. I think for the 30-minute window following vaccination for people who've had these anaphylactic reactions, I think, people are still feeling relatively conservative, and that's kind of why we've kept that 30-minute window in there. I don't know, Dr. Mbay, do you have anything you wanted to add kind of on this issue?
Sure. Hi, can you hear me?
Yes.
Great. Yes. So we have been thinking through that. We have conducted analyses of the anaphylaxis cases that have been reported so far and trying to understand the incremental benefit of a 30-minute wait period for high-risk patients. And it is something that we've considered and have talked about, but I think we would like to review a little bit more data before making such a decision. So we'll continue to review the data as data are collected. But as Jessica said, for now, we prefer to keep the 15-minute observation period as a minimum and then 30 minutes for people at increased risk.
Yeah, I don't argue with the 30 minutes for high-risk people. I think, from an implementation standpoint, we do flu clinics all the time, large mass vaccination clinics, and I would say the majority do not monitor for 15 minutes. So this feels very different from other vaccines, even though I understand that recommendation is out there. Thank you.
Thank you. Dr. Palin.
So thank you, Ms. McNeil, for this great presentation. I'm going to follow up questions with that 28 days. So anaphylaxis to the 2 mRNA vaccines are very rare. And so I'm still struggling with where did this information come from with 28 days later with Janssen, and is it needed? Thank you.
So the 28-day interval, and Dr. Mbe can correct me if I'm wrong, I believe that came from the interval that is being used between mRNA doses if one product is unknown, because likely one of those products could be a Moderna vaccine. And I think we just carry that forward for this recommendation as well. Sarah, Dr. Mbe, do you have anything else to add?
No, I agree. I think we felt like we did need to provide some interval, and we wanted that to be an appropriate interval, not only for reactogenicity considerations, but also to ensure a good, boost if it was going to be given as a dose after a previous mRNA dose. So we felt that was the most reasonable, because that would be that's the interval that we say when they're unknown mRNA doses, but also that's the kind of the maximum interval right now between the licensed label or the authorized indication for the Moderna vaccine dose. So that's 28 days. That's kind of, we have 21 days for Pfizer and 28 days for Moderna, so we opted to go for the longer interval when we made that recommendation for Janssen.
Dr. Daly.
Great. Thanks so much. So I do agree with the proposed clinical considerations related to vaccination. Could we go back to precautions for a sec? Because I had a question about that. Actually, the slide that has contraindication precaution and then may proceed with vaccination. So I was staffing a large vaccination clinic a couple weeks ago, and I was amazed at the number of true precautions that came up, and then also the number of things that really were not precautions but were perceived as precautions. And I think what I'm concerned about is just that there's a number of for a number of these individuals, the individual risk balance was still strongly in favor of vaccination that day. And these were folks who may have had, significantly increased risk of COVID disease. And so sort of waiting because of a precaution puts them at risk of COVID. So my question is there a place for us to clarify that in the vast majority of cases, if there's a precaution to vaccination, the idea is that they should be vaccinated that day after, maybe a conversation with whoever's there, and perhaps just observe for longer. Again, I just want to make sure that folks aren't misinterpreting the precautions as a reason to wait a couple months to vaccinate, because that in most cases is not a good idea.
Yeah, thanks for that comment. And we'll definitely go back and look at the language we have in the guidance and see if we can make sure that is clear.
Super. Thanks so much.
Thank you. Dr. Sanchez.
Thank you, Jose. No, I also agree with the recommendation, but I was wondering, with respect to the previous question about the 28 days between, I believe that yesterday, when I asked about concomitant vaccinations with the Janssen product, that they said that they were not being given from 1 to 2 months surrounding that. So I was wondering if that was part of the 28 days also, in terms of the time that the Janssen study did not allow other vaccines. However, having said that, I am very much in favor of having a more lenient approach to other vaccinations with any of these three vaccines. So like flu and hepatitis A and other vaccines. So I'm glad that you have that way out of also allowing other vaccines to be given at the same time, even if there's not great studies on that.
Thanks for that question, Pablo, Dr. Sanchez. So I agree. I think that all of the studies kind of handle this issue differently. In the guidance in terms of concomitant administration, I had a slide on this. We do say that there should be 14 days between the administration of COVID vaccine and any other vaccines, unless there's an urgency to somebody receiving a vaccine, for example, tetanus for wound prophylaxis. So I don't think we necessarily took that into account for the 28 days, but I agree that, yeah.
And this is Amanda. I just want to add that we are looking very closely at this concomitant administration and the 14-day interval, and we're going to be looking at our safety data to evaluate whether or not there is an ability to relax that guidance in the near future.
Dr. Lee.
Thank you. I wanted to move to slide 9. I just had one maybe statement, and not necessarily a change, but just with the recognition that we're going to start vaccinating younger and younger populations in the coming months. That I do still worry about late complications of COVID, such as MIS-C or MIS-A. And so even though there is, then one before this. So even though there is no minimum interval between infection and vaccination, other than the quarantine restrictions, I would say from a clinical standpoint, advocating for, waiting 4 to 6 weeks makes sense to me, just to make sure that we're not conflating late complications of COVID-19 infection versus adverse events of vaccination. But, there may be many considerations that are important in terms of the timing. And so if there is an elevated risk, obviously I would not necessarily want to delay. So I'm okay with this, but I just want to kind of state that for the record. Thank you.
Thank you. Dr. Daly, did you want to make a comment, another comment?
Oh, no, that was a slow hand down. My apologies.
Very good. Dr. Stinchfield.
Yeah, Patsy Stinchfield from NAPNAP. One thought I'm having about pregnant women is I'm glad that the professional societies are supporting vaccination with all the products available. But fever in a pregnant woman is something that we want to avoid for the fetus. And wondering if the J&J product would be preferable for that reason, that you cut your chances of fever in the baby because it's just one dose.
We're deciding who's going to respond.
Hi, this is Dana Meany-Delman. We did discuss that with our colleagues at ACOG and with others, and really decided we did not want to limit the opportunity for any vaccine. So whatever vaccine a pregnant woman has in front of her, she should receive. And we do include in our guidance that acetaminophen can be given if temperature rises. So we think that will address the issue. Thanks.
Thank you for that question. Dr. Cotton.
Thank you. Overall, the considerations presented are excellent. I just wanted to highlight one word on slide 13 in the middle of the slide where it says, all currently authorized vaccines are inactivated vaccines. And I might think about a different word besides inactivated, in that implies that they had been active and were rendered inactive. And I think just for uptake and just for clarity, this is a non-replicate, the J&J is a non-replicating viral vector, and then mRNA vaccines were never active in any way. They're mRNA. So I might think about semantics around that word just so that there's potentially better understanding and better uptake in the immunocompromised population.
Thank you for that comment. Yeah, we can go back and make that change in the guidance.
Very good. Thank you very much. I'm not seeing any other hands up. I think, have we answered your questions, Ms. McNeil? Yes. Okay. So it looks like we have. Okay. So we'll close this session.